Our next speaker will be Dr. Samar Ojaimi. She's a PhD student with Mark Pellegrini with a clinical background, and she's exploring using pro-apoptotic therapies for treating, for example, tuberculosis.
Thank you. Good morning, everybody. Firstly, I'd like to start off by thanking the organisers for inviting me to speak. So we're changing focus and talking about infection rather than malignancy. But before I start, I'd like to thank the people who've done most of the work, other than tuberculosis work that I'll be presenting. Most of it was done by my colleagues in the laboratory, including Greg, Cody, Michael, and James. So chronic infections. I deal with them in my clinical practice on a relatively day-to-day basis. They're significant, they've got a big impact, and I see it day to day, hence my interest in this, particularly tuberculosis. If you take hepatitis B, over about 2 billion people currently have been affected by hepatitis B, whether it be cleared infection or whether they be chronic carriers. Approximately 250 million people are chronic carriers of hepatitis B, and of these, about 600,000 people die from hepatitis B-related causes. And the complications of hepatitis B include cirrhosis, but also hepatocellular carcinoma. And despite a good immunisation program, it remains quite a big problem in the world. HIV, while it no longer is no longer the death sentence that it used to be, it still affects, 37 million people live with HIV. 2.1 million infections are acquired new every single year, and about 1.1 million people still die of HIV and AIDS related illnesses. And the complications of HIV include not just AIDS and the infections and the conditions that occur with this, but also malignancy with increasing incidence just relating to the virus alone, but other chronic conditions relating to HIV, including the increased predisposition to cardiovascular disease and poor cardiovascular health. But the other thing I'd like to point out is people with HIV, to survive HIV, have to live with on an antiretroviral therapy, which are your combined drugs that are used to control the virus. But there's no cure for HIV. I recently acquired the care of 2 families, one with 3 children, the youngest being 4 years old. When I think of that little girl having to live with these drugs for the rest of her life, not to mention the potential side effects that these drugs arise, there's no doubt we need something more than what we've got at the moment. Tuberculosis, which is one that's close to my heart since it's the focus of my PhD, affects 2 billion people. Most of it is latent infection. It's sitting there not doing much, but has the potential to do more. And about 10.4 million people have active tuberculosis, and about 1.8 million die from mycobacterium infection. And not to mention the increase, there's disability associated with these infections depending on where it affects, and it can affect anywhere in the body essentially. So normally in a setting of acute infection, what happens is that you have cells that get infected, that then these cells get taken up by antigen-presenting cells, where lymphocytes and immune cells are activated, that then go back into the area and fight and kill these infected cells, allowing a chance for new cells to come and infection to clear. In a setting of chronic infection, on the other hand, these cells are resistant to death, whether it be due to virulence factors or other inherent factors that allow them to keep going. And instead what they do is they promote more inflammatory cells to come in, and you get this inflammatory milieu, new infections setting in, and this process ongoing. The focus of our laboratory is essentially to try and see is how can we get rid of these infected cells and stop this process from occurring. Now, Gabriella beautifully introduced the work looking at SMAC mimetics and cell death processes, and this work focuses predominantly on the extrinsic pathway of cell death. And so I won't really go much into it other than to say that SMAC mimetics work by degrading the IAP proteins, which then stop the pro-survival mechanism that allow these cells to keep going. And instead, what happens is that they're channeled through the death so that you actually get apoptosis. So the molecule we use is what Gabriella introduced as Birinapant, which is a bivalent SMAC mimetic. It's well tolerated generally in some of the clinical trials that it's been used for. So I'm just going to skip through this and move on to talking to you about hepatitis B. This work has been published and was done by Greg. Now, hepatitis B model involves introducing the hepatitis B genome through an adenoviral vector through the mice. And the infection simulates very much a human disease in that mice initially are able to control the infection before getting breakthrough viremias. C3H mice, and these particular ones have a functional TLR, toll-like receptor 4, are unable, due to inherent reasons, genetic reasons, to control the virus. The nice thing about this infection is that early on, as the immune system tries to control the virus, is that there is a peak of TNF, which is essential in terms of clearing the virus, yet despite this, there's still no clearance, and the virus itself embeds into the DNA within the liver hepatocytes. So Greg has shown that IAPs play an important role with regards to hepatitis B. And in fact, when you use mice that are depleted of CIP1 and 2, there's earlier clearance of the hepatitis B within hepatocytes. There's a more greater degree of seroconversion and clearance of viremias as well. But also, more importantly, there's less liver genome involved as well. Now, I won't really have the time to go through into in terms of standard therapies that we have, but entecavir is a drug that is used in hepatitis B. The way it works, it's a nucleoside analogue, and all it does is essentially stops reverse transcription from happening and viruses being released and produced, but all of the particles of the virus are still being produced. And Birinapant, when used in these mice, has a similar efficacy to entecavir in that it reduces the viral load quite significantly, and it's quite similar to entecavir. But what's more important is that entecavir has no effect on the surface antigen production or the viral particles that are being produced, whereas Birinapant is able to stop this, suggesting that it has a direct effect on the actual cells that are infected with hepatitis B. And here we can see that Birinapant reduces the actual hepatocytes that are positive with hepatitis C as well. Show you this diagram here. So these are cells that are positive for core antibodies. So these cells actually have the hepatitis B virus within them. And we can see here, these are untreated versus treated. And following treatment, this is a picture that shows tunnel staining indicating dying, apoptosing cells. What happened, you can see superimposed that only infected cells are actually being killed by this. And as a result of the work that Greg has done, Birinapant is actually going into clinical trials with regards to treatment for hepatitis B. And the endpoints will be how well tolerated the drug is, effects on liver enzymes. If you can imagine, potentially when you're killing cells, there's a rise in liver enzymes, but also surface antigen and the human ability to actually seroconvert and clear the infection, as well as the pharmacokinetics and pharmacodynamics. So moving on to the human immune deficiency virus, this is work that's done by Cody. So this virus infects only human cells. So really, we're very much limited when it comes to investigating and testing out new drugs. And the only efficacious way is this new model that's essentially been set up. Now, this preclinical model involves getting immune deficient mice, giving them human stem cells and allowing them to develop a humanized immune response, immune system. And then coming along and infecting them with HIV before treating them with standard therapy. So as I said earlier, HIV is treated with antiretrovirals, usually involving at least 3 drugs, before then resting the mice and allowing the virus to come back up. And what Cody's shown is that this model very much simulates human infection in that mice are able, with the antiretroviral therapy, can control the virus. But then as soon as you stop this peak, it comes back up because the virus lives within the cell and we're unable to clear latent infected cells. So looking to see what effect Birinapant has directly on infection, Cody treated mice about 1 week following giving them the virus, and what he found is that Birinapant significantly reduced viral replication. But what was more important is when we measure HIV-DNA, which is a virus incorporated into human DNA, there is a significant reduction with Birinapant. But really, I mean, treatments are very effective, but the key with the treatments that we have at the moment is that they don't kill latent cells. You stop the treatment, virus comes back. And so we're looking at ways to try and stop this process from happening. How can we, purge the cells or get rid of these infected cells? And so Cody gave Birinapant in the midst of actually giving them these drugs while they were completely suppressed, and had a look to see afterwards when we stopped the drugs what happens. And what he found is that Birinapant, in fact, delayed the return of virus, and when the virus did return, it was significantly, more reduced when compared to untreated or vehicle-treated mice. And so moving on to the virus that also causes very much latent disease. The human T-cell leukemia virus, as the name suggests, induces adult T-cell leukemias, but also causes myelopathy in different parts of the world, infects different populations somewhat differently. Its relevance to Australia in that it's quite endemic and prevalent in the Northern Territory and central parts of Australia as well. While it causes rare conditions, it's associated with more common conditions, including, if you think about that population being a higher risk of cardiovascular disease, as well as higher risk of common infections, there's a quite strong association between this virus and those conditions. So James is looking to introduce this model into the laboratory. And essentially using humanized immune system mice again, he infected them with splenocytes before treating them with Birinapant and looking at therapeutic efficacy of Birinapant. What was striking with this is while at the time that he was giving them Birinapant, the lymphoproliferative effects of this virus essentially stopped. It was completely halted. It did nothing compared to the DMSO where the cell continued to go up. Now, looking at the actual viral genome, little difference was seen. But the problem with this model is that, unlike humans, where only about 30% of immune cells are infected, in mice, all the cells become infected. So it's really hard to really assess efficacy. So James at the moment is looking to see whether giving antiretrovirals early on, we can restrict the amount of infection that can occur before then coming along and assessing Birinapant. But certainly, it's sort of, in terms of being a novel mechanism, if you think of these viruses being latently infected, maybe potentially a dose, maybe all that needs before they're purged. But I mean, it's really hard to say, and this is very much a very early preclinical model. So moving on to tuberculosis. The thing with tuberculosis is that it's an intracellular host. It coexists with humans and has coexisted for many, many thousands of years. It lives and is able to manipulate the immune system, and that's what makes tuberculosis so difficult to control. And the problem is that when these latently infected cells, which are sort of dormant cells, then become out of control, people then potentially can become infectious and can pass it on, and it becomes a vicious cycle. And so, looking to see whether we can somehow, what effect Birinapant might have in tuberculosis, I firstly looked to see what these proteins, the inhibitors of apoptosis, do in the setting of infection, and found that when infected human monocyte-derived macrophages, is that these proteins were actually increased in the setting of Mycobacterium tuberculosis. Interestingly also, when I infected CIP1 deficient mice, found that they had quite a significant reduction in bacterial burden. There was about 10-fold reduction in tuberculosis in these mice. And that was also associated with an increase in TNF. And we know generally from both human disease, when people who are immunosuppressed with anti-TNF therapy reactivate their TB, is that TNF is actually quite essential for treatment for control of tuberculosis. And so this essentially suggests that there's a role that these proteins play in tuberculosis that we wanted to explore further. So in our model, we infect mice, and then they reach, the organism reaches stability by about day 28, and then at that point, I start treating them. I've done quite a lot of work and a lot of trials and regimens to try and come up with essentially the best one. And the best one is this approach where I've labelled as the big hit and rest approach, where we come along with Birinapant, we treat the mice, we kill the macrophages, but then allow new macrophages to come about, allowing TNF to come back into the system to induce further killing. The reason for that being is that the organism itself, while it grows within the cell, is just as capable of living outside the cell. And so killing these cells with the drug may not necessarily completely eliminate the bacteria. And doing this approach, I found that there was a 10-fold reduction in the amount of tuberculosis in here. Now, this is quite a significant reduction when we talk about this particular organism, and not just in the lung, but also in the spleen and its ability to stop it from disseminating. Mice are not natural hosts of tuberculosis, and so we're looking to see whether humanized mice will show us a little bit more and for us to be able to explore this preclinical model a little bit better when it comes to tuberculosis. Tuberculosis being a very significant condition with really not many models at all for us to investigate this severe infection. The only other model that's been used is zebrafish, but again doesn't have the immune system that's required to teach us and tell us more about tuberculosis. And with these mice actually develop very much what we human granulomas composed of very similar cells as humans. And so when I gave Birinapant to these mice, didn't find much of a difference in the lung, and I think that might be sampling bias. We're trying to maximise, we don't have much of these, trying to maximise how much information we get, and this is probably sampling issue, but what was important, what was also interesting is that there was a significant reduction in splenic burdens with these mice. So moving on to a bacteria that's not able to grow outside of the cell. So milioidosis is a condition that it can have an acute form or a chronic form and results in acute sort of pneumonia plus skin infections, and it's caused by an organism called Burkholderia pseudomallei. It's endemic to, again, the northern parts of Australia. And this work done by Michael. So Burkholderia, as I said, is not capable of growing at all outside the cell. And so giving the mice to breathe it in, and that's essentially how we get it. We breathe it in, and so it simulates human disease. And then mice are treated with Birinapant. And this impressive result basically occurred that these are very much preliminary data and early results that are being explored. But essentially Birinapant has the exact same effect as antibiotics. These antibiotics would need to be given multiple over a number of days to stop infection from happening, whereas Birinapant was a single dose significantly reduced the amount of bacterial burden. So now, this essentially concludes the work that I'll be showing you. But essentially, I hope to have shown that this is potentially a novel way to think about treating infection. Most of what we do targets the organism, targets the virus, but little work goes on to target the host. And these are, there's lots of potential ways that we can target the host, and I think this is one particular way that potentially has some promising effect. Which is unfortunate that short of treating humans, there's little good models that we've got for a lot of these conditions. So just that just leaves me to thank particularly Mark, who's the mastermind behind all of this, everyone in the laboratory, and everyone really who's helped out in so many different ways.
So I hope the microphones will come around. Just raise your hand. But in the meantime, could you tell us which of these models you believe has got the clearest path to the clinic, where you can see exactly what might happen or what needs to be done before you could go into the clinic?
Yeah, so I think each of the conditions will obviously be different in terms of, so hepatitis B, I think that's already ready to go. It's been looked into, being started very soon. There have been very preliminary results, very much early pharmacodynamic and pharmacokinetic sort of data with that. And I think that the restricting thing might be potentially a side effect. So, one of the patients developed a sixth nerve palsy, and thought to be potentially related again to that potential effect on chronic viruses such as the herpes virus, which can cause a kind of a Bell's-like palsy. So that model is ready. In terms of things like the tuberculosis model, it's really hard to move it straight from this into human trials. And really, I think the only way that I can see this potentially moving forwards is through primate models, potentially, which are really hard to get. There's very few people who deal with it. Numbers are not big, etc. Yeah. It's the models that make it a little bit tricky.
Right. Any questions from the audience? If not, then we'll just thank Samar.
Okay, thank you.